So hello friends and welcome you all to Sail to MDS Dental Academy. Today we are here with the lecture number 15 on endodontic emergencies before the treatment. Today we will cover the pulpal and periapical diseases. So friend, please watch the video till then, like the video, share with your friends and subscribe the channel. So let's get started. So friends, now we'll study about endodontic emergencies. This chapter is very important for the MDS aspirants because nowadays in exam they are asking case scenario. They will give a name of patient with their sign and symptoms, and then they will ask what are the condition and different questions pertaining to that condition. So it is very important for you people and also for the clinician, as we know that out of 10, 5 to 6 cases will be of endodontics. The patient will come like this picture with a hand on the face and they will be in some or the other kind of excruciating pain. So it is endodontic emergencies. So today we will discuss endodontic emergencies before the treatment. So we will study about the pulpal and periapical diseases. So what is endodontic emergency? It is an emergency. What emergency means? You require an unscheduled visit, prompt treatment and a prompt diagnosis. So endodontic emergency is a condition associated with a pain or a swelling that require immediate diagnosis and treatment. So what are the main cause of pain in endodontics? It can be a pulpal pathologies or a trauma to the tooth. So why pain will occur in endodontics? Because of two things: the chemical mediators. These chemical mediators will cause pain by lowering the threshold of pain of your sensory nerve fibers. The second reason is a pressure. What happened because of inflammation, there will be the edema, and this edema will cause increased fluid pressure which will act on your sensory pain receptors. That will cause pain. Now there is a difference between the word true emergency and the urgency. So please my MDS aspirants, note down that whenever you are reading any question for the AIMS or NEET exam, you should read the question properly. The word like true emergency and the urgency many times cause a confusion. So the true emergency means there is a unscheduled visit and you require prompt diagnosis and treatment at that time only. But urgency indicates a less severe problem in which a visit may be planned as per the convenience of both patient and clinician. Okay. Then how we will classify this endodontic emergencies? So I told you it will be the before the treatment, during the treatment and after the treatment. So today we will see the endodontic emergencies associated before the treatment. So now we will see cracked tooth syndrome. So what is cracked tooth syndrome? It is an incomplete vertical fracture of tooth. This fracture will involve enamel and dentin, but sometimes it involves pulp also. And when it involves pulp, it causes excruciating pain. This cracked tooth syndrome is most commonly seen in mandibular molars, followed by maxillary molars and maxillary premolars. Remember my friends, you should know this commonly seen, okay? Because nowadays in AIMS exam they are asking sequence based question. So which sequence come first and last you should know. So cracked tooth syndrome is most commonly seen in mandibular molars, followed by the maxillary molars and maxillary premolars. This cracked tooth syndrome occurs most commonly in the teeth having a class 1 restoration and those who are unrestored. Okay, but remember there should be opposing plunger cusp. This is a plunger cusp which will occlude centrically on the marginal ridge. This is one of the most common cause for the cracked tooth syndrome. So the most important clinical note will be the patient will complain of pain, either of the mild type or a severe type, at the initiation of bite and on the release of biting pressure. This is the most important diagnostic sign for a cracked tooth syndrome. And you can use certain diagnostic aids like a fiber optic light. You can see in the diagram how the regular light appears. When you use the fiber optic light, you can see the fracture line. Okay, here it has been marked. Then either you can use the magnifying loops for increased magnification. You can use the dyes like a methylene blue that help us to locate these crack lines. But the most reliable tool is the tooth slot. The tooth slot is a pyramid type of a plastic bite which have a concavity at the apex, and in this concavity your cusp will sit. So that helps you to identify that which part of the tooth is involved. So it's very important and most reliable tool to diagnose cracked tooth syndrome. So now how will you treat this cracked tooth syndrome? If the crack is there in the vital teeth, okay, or it can be there in the non-vital teeth also. In the vital teeth, remember the first thing you have to do is the selective grinding of the tooth to de-occlude your tooth, okay. And second thing is that if the cracks is not involving the pulp, then you have to go for the pulpal protection. You can go for the occlusal adjustment, go for your cuspal protection, do the restoration via composite or a cast restoration. If the crack involves the pulp, then remember it will cause a pulpitis and necrosis, so root canal treatment is advised, followed by a full coverage restoration. The ideal treatment for a cracked tooth syndrome is full coverage restoration. Remember a rule of thumb that if a crack involves a root canal, you have to extract the tooth. If the crack involves the pulp chamber only, go for the endodontic therapy and restoration. If a cracks occur in the root field or non-vital teeth, the treatment is full coverage restoration if you can save the tooth. But if in case the crack is vertical involving the entire root, the extraction is the preferred choice. So now how you will differentiate between this cracked tooth syndrome and your vertical fracture of root. Remember, in cracked tooth syndrome, the crack will run occlusocervically, but in case of the vertical fracture, the crack will run from the root tip to the cervical direction. So now we will study about the symptomatic reversible pulpitis. The previous terms were acute reversible pulpitis. So according to American Academy of Endodontics, the term acute and chronic have been removed from the glossary of endodontics. So friends, never use the word acute and chronic. Rather than the use word symptomatic and asymptomatic, depending upon the condition of the patient. So now symptomatic pulpitis. So what it means? The word says that pulpitis. It means in case of reversible pulpitis, the inflammation will be of mild to moderate type, most often caused by any noxious stimuli. This stimuli can be the physical also, chemical also, or a bacterial. It is reversible. It means your pulp has ability to go back to its original state if we remove the stimuli at appropriate time. Okay, it is symptomatic in nature. It means it will cause mild to moderate pain. Okay, the pain will be of short duration and of sharp type. Here the characteristic of pain will be there that the pain is always specific to stimulus. Okay, it is most often caused by cold things rather than hot. So how will you treat this reversible pulpitis? Remove the noxious stimuli, provide proper pulp protection, and go for the restoration. Now we will see symptomatic irreversible pulpitis. Remember my friends, what is the difference between the reversible and irreversible pulpitis? The difference is quantitative in nature. What it means? In case of reversible pulpitis, you can trace the stimulus, but in irreversible, there are no specific stimulus. The pain will be there. The second thing is the duration of pain. Okay, here there the pain will be of short duration. Here the pain will be of the longer duration. You can say a lingering type of pain. In irreversible pulpitis, the patient often complains of two important things, that is a postural pain. They will complain of pain that when they are standing, on changing the position to lying down, they will have a severe pain. Why that pain will occur? The reason for postural pain is increased in intrapulpal pressure. And the second is a nocturnal pain. They often complain of pain during the night. Here the quality of pain will be the shooting type, gnawing type, or a throbbing in nature. So how will you treat this symptomatic irreversible pulpitis? The treatment is simple. You have to go for the proper endodontic therapy followed by the restoration. So friends, now we switch on to periapical disease. As we know that the pulp and the periapex are interlinked to each other. So whatever the infection on the pulp is there, it will spread to the periapical area. Why it happens? Because we know our pulp is a solid enclosed organ. No drainage is possible. Okay, so infection will travel to the path of least resistance. So the path of least resistance is our apical foramen. So whatever the infection is there in the pulp, it will travel to the periapex. Okay, so friends, now we will see symptomatic apical periodontitis. Previously, we used to tell it as a acute apical periodontitis. This symptomatic apical periodontitis can occur both in non-vital and vital tooth. Okay, we have discussed in the Cysts chapter. You can watch the video. The I button has been given above. That this apical periodontitis also occur in case of vital tooth, like in case of developmental disorders or neoplastic or cystic disorders. Okay, but in non-vital teeth, it mostly occurs because of some of the chemical means or a bacterial means or any kind of the physical trauma. So, symptomatic apical periodontitis, it is an acute condition that occurs just before your alveolar bones start resorbing. It is one of the most difficult emergency to treat because they are the symptom of both acute pulpitis and acute periodontitis, and along with that, it is difficult to anesthetize such tooth. Okay, so the most common symptom we can see, the patient complain that they feel like a tooth has been elevated from the socket, they are unable to chew on that particular tooth. So the most important diagnostic feature is the tooth will be tender on percussion. Why the tooth is tender? Because your periapical area has been inflamed. So whenever you percuss, the tooth will be tender. Remember, your percussion pressure should not be more than your finger pressure. So don't percuss very hard. Then when you take the radiograph of such a tooth, you will not find any evident radiographic changes. Okay, you can just see here the caries has been involved in the pulp, and in the periapical area you can see slight widening of the PDL or in some cases small periapical radiolucency. So if this has been left untreated, this will progress to asymptomatic apical periodontitis. To differentiate both, you have there will be the two things. The first thing is that in asymptomatic apical periodontitis, there is no tender on percussion. But the remarkable, the distinguished feature is that you can find the proper periapical changes. You can see the bone loss, periapical lesion, etc. So for now, we'll see how you will treat this apical periodontitis. First thing you have to do is the occlusion should be relieved. Okay, so your periapical area has a chance to resolve. Second thing, you have to remove the causative factors and you have to initiate proper endodontic therapy. And in this disease, you have to prescribe analgesic as well as proper anti-inflammatory drugs. So now you will see acute alveolar abscess. It is also known as periapical abscess, dentialveolar abscess, or a radicular abscess. What is this abscess? This abscess is an inflammatory reaction to your pulpal infection and necrosis. You can see in the diagram, the surface of this abscess region will appear taut and inflamed, and below this only the pus formation will start. Okay, the pus formation occurs because of the proteolytic enzymes like a cathepsin. Fine. So in alveolar abscess, we can see there is a localized collection of pus in the alveolar region. I explained before only that your infection will travel to the least path of resistance. So what are the symptoms you can see in abscess? The first is tenderness of the tooth. So the ear will be the different tenderness than your apical periodontitis. So sometimes this tenderness may be relieved if you give a slight pressure to your extruded tooth. Okay, so when the tooth will go into the socket, the patient may feel relief. So we always advise that whenever you are doing access opening of abscess tooth, you have to brace your tooth with your finger pressure. Second, the patient have a throbbing pain and they will complain that they have difficulty in the sleep. Okay, you can find the swelling of the overlying soft tissue with or without the mobility, and if it becomes so extensive, the infection can spread to the facial planes and can cause a space infection or a cellulitis. Why this infection will cause cellulitis? Because they have the ability to produce the hyaluronic acid. And also you can see the systemic symptoms because of the absorption of septic products like a fever, irritation, the patient have malaise, they have difficulty in eating, etc. So how to expect that where the swelling will occur? It depends upon the teeth. In case of mandibular anteriors, you can find the swelling in the submental region. Then you can see in the diagram a red line is there. This line is the mylohyoid line. So if the infection is so the tooth which are lie above the mylohyoid line, you can find the infection in the sublingual area like mandibular premolars or first molar. But if in case of tooth like second and third mandibular molar, the infection will be in the submandibular space. If there is a paracoronal infection, you can find the lateral pharyngeal space involvement. In case of maxillary canine, premolars or mucobuccal root of first molar, the infection will be in the infraorbital or canine fossa space. If your buccal roots of maxillary second and third molar are involved, then you can find the infection in the retrozygomatic or infratemporal region. And in most of the maxillary teeth, you can find the buccal space infection. And if your mandibular teeth rhodopaesis crosses the buccinator, in that case also you can find out the buccal space infection. So what are the treatment outlined for this abscess? You can have to go for the proper pharmacological management depending on how the infection is there, like aerobic and anaerobic infection. Mostly abscess area contain the bacteria, they are mostly anaerobic. Then you have to go for the occlusal adjustment, proper access opening of the root canal, proper endotherapy you have to do. Then along with that you require sometimes incision and drainage, needle aspiration, trephination and decompression. We'll see this treatment outline details in the following lectures. So now we will see the sequelae of pulpal disease. So as we know, when the normal pulp is subjected to noxious stimuli, it can cause reversible pulpitis that can progress to irreversible pulpitis, and then the irreversible pulpitis can progress to this fourth thing. It can go for a chronic hypoplastic pulpitis. What is that? That is a pulp polyp. It is a productive inflammation of the pulp. This pulp polyp is asymptomatic and the treatment is proper endodontic therapy and restoration. Then it can cause irreversible pulpitis that you explained before. Then internal resorption. When the cause of pulpitis is due to trauma, then it can cause the internal resorption of the tooth. So all these things can progress if left untreated to a pulpal necrosis. The pulpal necrosis are of two types. It can be a coagulative necrosis or a liquefactive necrosis. What is a coagulative necrosis? The word coagulation means something liquid is converted into the semi-solid or a solid. So you can see the pulpal tissue is sometimes converted into the some kind of the cheesy material or some solid substance. And it can also cause a liquefactive necrosis, that is, a solid material is converted into the soft amorphous or a liquid material. So there are two types of necrosis you can see in pulp: coagulative and liquefactive necrosis. The treatment is endodontic therapy and proper coverage. Sometimes the pulp has been subjected to a stimuli which causes a degenerative pulpal changes. So in such cases, we can see the calcific degeneration or calcific metamorphosis. What is calcific degeneration? It is a part of the pulp has been calcified. When such calcific degeneration occurs due to trauma, it is known as calcific metamorphosis. Fine. Then we will see the sequelae of periodicular diseases. So normal, when the pulpal disease progresses, causes apical periodontitis. This symptomatic apical periodontitis can progress to cellulitis or acute apical abscess. This acute apical abscess can convert it to chronic apical abscess. So when you see that sinus opening or a sinus discharge, it is known as chronic apical abscess. This asymptomatic apical periodontitis can cause chronic apical abscess or sometimes a phoenix abscess. What is a phoenix abscess? It is an acute exacerbation of a chronic lesion. So what is the difference between this acute apical abscess and phoenix abscess? In acute apical abscess, you cannot see any radiographic changes. You can see hardly a widening of PDL and loss of nominal dura. But in phoenix abscess, there will be pain and along with a distinct periapical changes. Sometimes this apical periodontitis can be connected to the condensing osteitis or a radicular cyst. Can be of two types, can be a periapical true cyst or a periapical pocket cyst. This radicular cyst has been explained in detail in the video of cyst of jaw. You can watch by clicking on the I button given above. So friends, that was all about pulpal and periapical disease, that is endodontic emergencies before the treatment.